Well, thanks, Philip. It's nice to talk here about research that we only finished a couple of weeks ago, probably less than a week ago. And we looked at how long vaccines indeed confer immunity using the COVID infection survey. Just to give a brief overview of what the survey consists of, I think it's the largest longitudinal survey in the world. And we take a random sample of households across the UK. So we have about 500,000 individuals in the survey from about 250,000 households. And we basically recruit everyone that is willing to participate, aged 2 years and over. And how it works in practice is that we have study workers actually going to people's households, and they ask them lots of questions from a pre-designed questionnaire, and they also take nose and throat swabs, so that they're self nose and throat swabs at enrollment and following for a month at a weekly schedule, and afterwards monthly. And for a random subset of people, we also take blood tests so we can monitor antibody levels. So the first participant was recruited in 26 April last year. And it was basically at the end of the first wave. But by now we have over 5 million swabs and about 775 blood tests. And basically, if you're interested in this is a collaboration with the Office for National Statistics, and they basically publish bulletins and articles every week that you can find on their website. So why we use this survey? Well, it's very large, as I mentioned before, and I think importantly, in contrast to many other studies that look at the real-world effectiveness of vaccination, tests are done independent of vaccination and symptoms, so you're less likely to have biases due to test-seeking behavior that changes as a consequence of vaccination. For example, if people believe AstraZeneca is less effective based on reports, they might go quicker for testing more often than if they receive Pfizer, etc. In addition, because we were able to ask a lot of questions about the participants, we had data available on lots of risk factors that are typically not available in other research, such as what kind of job people have, household characteristics, so how many people lived in a household, so what's the risk of infection, and whether people had indirect contact with hospitals and care homes. And we use slightly more complicated methods than most other studies do, allowing us to adjust for the so-called force of infection using flexible tensor splines. And I have to note for the subsequent analysis that I will present, they are all restricted to those aged 18 to 64. And basically that's because there's hardly anyone left in the UK, and especially in a survey that's older, so 65 years or older, and that's still unvaccinated and not previously positive. And basically how I always tend to explain it to reviewers, or you can't compare apples to oranges if you only see apples. And I think going forward, it is a problem for many studies evaluating effectiveness, at least in the UK or similar countries with a high vaccine uptake. So here I'll focus on effectiveness waning, or the potential of waning. And what we found in our study is the effectiveness was initially higher 14 days after a second dose with Pfizer compared to AstraZeneca. So the difference was 92 versus 70%, depending on whether you looked at symptomatic infections or high viral burden infections. However, the effectiveness seemed to decline faster with Pfizer than for AstraZeneca, resulting in kind of predicted similar effectiveness after about 5 to 6 months. However, it's important to emphasize that the vaccines by this point still provide really good protection, and much better than the original threshold that the WHO had set for reasonably effective COVID vaccines. before vaccines were developed. So subsequently, we looked at, is there any evidence of different effects in different people? Because you basically want to know, like Andy previously talked about, are there certain groups that might actually be eligible for a booster dose while the majority doesn't need it? And what we found, unsurprisingly, that there is better protection among those previously infected. And this is quite important because the way we defined reinfection basically means that those with a prior infection were all infected previously by alpha or an earlier kind of wild type variant before. So basically those type of infections also protect against the Delta variant. And importantly, vaccination plus previous infection was also better than previous infection alone. And elsewhere in the study, which I won't show, we basically saw boosting of antibodies when someone was already vaccinated and got a positive test, suggesting that at least subsequent exposure also likely leads to better subsequent protection. The other thing we looked at was age, which we basically defined it, the age categories into half. And we found that protection tended to be better in young people compared to older people. And remind that this is all under 64 years and below. And well, this might be expected given how what we see from other vaccines. And unfortunately, we didn't have that enough data to split everything by all possible factors. So this is only for AIDS and the previous one is only for prior infection. So part of the AIDS effect might be due to young people having more prior infections. And this is something we're going to look at in ongoing future. And something that has been discussed in the literature recently, especially given the high hospitalization rates in Israel, is whether a dosing interval matters. And sorry, what we basically did is look at, basically use the slightly arbitrary split for the dosing interval. And we're, sorry, and we split by people on a dosing interval, so time between first and second dose, less than 6 weeks and 6 weeks and over. And as you can see from this plot, while the vaccine effectiveness against infection reduces over time, we didn't find statistically significant differences between the two, although the shorter dosing interval was consistently lower regardless of what outcome you looked at. So we found it for all infections, symptomatic infection, and high viral burden infections. So to summarize, we found that 2 doses of Pfizer had greater initial effectiveness against new COVID or SARS-CoV-2 infections, but it declines faster compared to 2 doses of Oxford AstraZeneca. And vaccines, as also emphasized by Andy previously, vaccine effectiveness likely remains high as hospitalization and death rates have only increased by small amounts in the UK, despite very large increases in the number of people testing positive. However, this is in contrast with Israel, where hospitalizations have substantially increased and effectiveness against hospitalization appears to be waning, according to some reports. But it's a bit unclear whether this is due to confounding. So people that were vaccinated early were, of course, people that were frail and old. And basically, the absolute risk of someone to end in a hospital is probably higher for a vaccinated 80-year-old than an unvaccinated 20-year-old. There might be some testing bias, or indeed a dosing interval issue where almost everyone was on a 3-week schedule in Israel, which is also one of the hypotheses that a lot of people have. So to put this all in perspective, I think I agree with previous speakers that as long as protection against severe disease remains good, there's no clear rationale for boosters. So there might be specific subgroups, but vaccine policies should not be made based on waning antibodies, which they are expected to do anyway, or waning effectiveness against infection alone. However, it indicates that we should monitor potential waning effectiveness against severe outcome closely. And some challenge there is that, for example, in the UK, if there's hardly anyone left that's at high risk of hospitalization, so old people, then it's really hard to keep assessing the vaccine effectiveness. And something to take into account, whether countries already hoard vaccines, even if deciding postponing booster for most. And that seems to be happening, at least according to some unofficial sources, that might already be the case, which is also problematic. And then again, global stock of vaccines still limited, so providing booster doses likely delays vaccination in some low-income countries where the majority is still not the opportunity to get vaccinated. Yeah.
Sorry, yeah. We're just on the interest of time, maybe another 30 seconds, and yep.
Yeah, so basically on your question, Philip, I think a similar study compared to the coronavirus infection survey in a low-income country is just not feasible if you do it exactly the same way, because it's essentially really expensive to go to households. And so it is something I'm interested in and also put a grant in on working out how we can do something similar, but in a much more affordable and cheaper way. And maybe we have to think about wastewater epidemiology, which is potentially easier to set up in low-income countries because it's much more affordable. But then the systems there are also closer. So it's definitely something I'm keen to work on, but I don't have an answer yet.